Assalamu alaikum. Yesterday we started some points about like what are important anesthesia concerns when we are dealing with patients with ENT surgery. So I will just quickly just have a quick review that actually there is risk of bleeding. There is shared airway. Okay, there is limited access to the patient. Okay, with reference to adenotonsillectomy, there may be chances of OSA, there may be chances of recurrent infections. Okay, and if we have pediatric population, so the pediatric concerns, like in the form of anxiolysis, difficult IV, all physiological, pharmacological, and anatomical consideration in pediatric population. Okay, so and then with reference to if we just think about some nasal surgeries, so usually if they like there are some surgeries which are cosmetic and like rhinoplasty, um, and some of them are like sep- just a second please, if you can mute your mic. Okay, septoplasty or and like FES, functional endoscopic sinus surgery. So in these nasal surgeries, the concerns which we all face is that they are asking for hypotensive anesthesia. Okay. So with this reference, I will just highlight few of the points that it is ideal that you should take arterial line because without arterial line, we are never sure about the blood pressure. When you are taking arterial line, you should zero it at the level of tragus, like external auditory meatus, okay, rather than at the level of heart. Because if you are leveling it at the level of heart, because they usually they are making it a little head up. So and they are if they are asking for consistent 60 mean, then because this may cause some if not hypoxia, what other implication can occur in such patients, because these patients are at more risk of delirium. Okay, so if these patients remain with persistent low blood pressure, there the incidence of delirium will be increased, because when we finish the surgery, the I'm sorry, the nasal cavity is blocked, so they are usually very aggressive. It's very difficult to keep them calm, and sometimes it becomes a big challenge to handle these patients. And that's why like usually, even if we are not usually placing oropharyngeal airway in all the patients, some people have the habit of putting airway in all the patients, and I have a lot of concern, because there will be a lot of problems which this oropharyngeal airway can cause, because it will be irritating the airway, and it can lead to some exaggerated responses. But it is better to place airway in, at least in such patients, because their nasal cavity will be blocked. And it sometimes become, if they these become, if some bleeding occurs post-operatively, these patients have more chances of having laryngospasm or uh, airway obstruction. Okay, so you have to anticipate and manage accordingly. So with reference to hypotensive anesthesia, one few points that actually you should take the baseline blood pressure, not the blood pressure which you are taking inside the OR, because sometimes this will be a little higher than his normal routine. So you can just take, if they want it's better to discuss with the surgeon about their about his requirements, about his plan before every surgery. But especially if they are asking for hypotensive anesthesia, you should just tell them with their baseline that this is the baseline round. For example, if the mean is around 80, uh, so you can bring it up to 60, for example. I'm talking about mean arterial pressure. But if the mean is more than 100, for example, like blood pressure reading is 180 by 100 or 160 by 90 consistently, so the mean blood pressure will be higher. So now if you bring this patient persistent for 3 to 4 hours around 60, at especially when you are using the non invasive blood pressure, so this can create problem, especially if the patient has some comorbidities like diabetes or hypertension. Okay, so this is a very very important consideration. And can anyone tell by what is the way to see or to indirectly look at the level of activity going on in the brain? Can we just indirectly monitor this patient? Any answer, please? Yes, what one answer has come? Very good. Okay. So the answer is BIS. We can monitor through BIS. Okay. Sorry. Okay. So we can monitor through BIS. Okay. And of course, as I told you, that ideally we should take arterial blood pressure monitoring. So this is mandatory. Then another problem that they are adding vasoconstrictor. Okay. So vasoconstrictor, they are adding epinephrine. So I think I don't remember that I discussed this thing yesterday or not. Usually the preparation which is available is either 1 in 200,000 or 1 in 150,000, depending on different. So this is around 5 microgram per ml. Okay. This is okay if they are using lidocaine 2% with 1 in 200,000 of epinephrine. But sometimes what happens that this preparation is not available. Okay, 2% lidocaine. So what they do, they take 1 milligram and they put it in certain amount. So actually, you have to be very careful that what concentration. If they have taken 1 milligram, ask them to dilute it in 1 liter or at least in like 500 ml, so that the concentration is not too high. Okay, because if they added it one milligram, for example, in 100 ml, so the concentration will be very high. Okay, so it will be around 10 mics. So you should be knowing which concentration they are using. Okay, and because this absorption of epinephrine will be variable. No, it will not be alike in every patient. Okay, and if all of you will appreciate that whenever they are injecting this local, they always tell us that doctor, we are injecting local. So do you think, and in modern anesthesia, is it important for us to know that they are injecting local? Actually, before they maybe few decades ago, we used to have halothane. Okay, so halothane plus epinephrine, it was a lethal arrhythmogenic combination. Okay, so this was the reason that they still remember this thing, though they don't know that we don't use halothane now. This is one thing. And actually, with reference to epinephrine, usually they are using lidocaine. So lidocaine is not that much dangerous for us as compared to marcaine, that is bupicaine. Okay, so this is an important consideration. So one thing will be that you ask them to have head side up. So because if you will make head side up, the upper extremity veins, they don't have valves. Okay, so 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 they are valveless. So if, for example, you make head side a little up, so there will be decrease engorgement. Okay, so when there is decrease in engorgement, then there will be decreased bleeding. So this is one of the factor. And also you can like not only not only this only head side up, you can make reverse Trendelenburg. Okay, reverse Trendelenburg, because what will happen, there will be decreased venous return, and you can control the blood pressure. Because people, I have seen that people immediately go for antihypertensive, labetalol, or any hydralazine or anything, or nitroglycerine. This should be the last resort. Okay, it is better that you have a lot of options to get this hypertension. You can use propofol infusion. Okay, you can use dexmedetomidine, you can use remifentanil. Okay, you can use like increased mac. Okay, so there are so many options which you should give good amount of analgesia, multimodal analgesia with paracetamol, NSAID. Okay, and also if you are using opioid, then morphine is a better choice, and it will make the keep the patient more stable than any other opioid. Okay, so these strategies you should use before going for antihypertensive. Okay, and of course there are two group of people. Some people don't use nitrous oxide. So nitrous oxide is an excellent analgesic, and unless you are doing middle ear surgery in which there are problems with the cavities, or at the before the end of the surgery, you can close it. But during the surgery, when the sinuses are open, there is no problem in you using nitrous oxide. Rather, it will reduce the MAC requirement, and actually it is a very good analgesic. So when there is good analgesia, there are chances of having good surgical field. Okay. Then another point with this reference, um, yes, with this FES. Okay, sometimes actually you are not too much familiar about what they are doing. Okay, so it is better to have a communication with them, so that you know which level, like how much extent of surgery is left, so that you can like manage your anesthesia accordingly. Because sometimes there are some critical steps when they really need surgical field to be bloodless. After that, when they are finishing, when they are just like closing or getting, so sometimes actually they need the blood pressure to be normal, so that they say that there is some oozing or not, and they have removed the required tissue or not. So it is better to communicate. And then another, am I audible? Can you hear me? Yes, Dr. Vaji, you want to ask something? You hear some of you raise the hand. So you want to ask any question? Am I audible? Just let me know, because there was some problem in my internet. Yes. Okay. So there is one complication which can occur, CSF rhinorrhea. Okay. I was asking some of the ENT surgeon. So there are incidents of CSF rhinorrhea post-operatively after FES, because usually they are very like they are meticulous, but still you can have this thing. And because which surgery in which they approach the patient through this route, can anyone tell which is the surgery in which they do a neurosurgery from this route? Actually, transfinital resection of pituitary. Okay, pituitary surgery is, yes, thank you. So you just have to correlate the things. And just a second, there are some, yes, okay, so thank you. So actually this is all about it. Usually we place throat pack. Okay, throat pack has all its implications with reference to its material. Okay, its size and its preparation with so it should be soaked, it should be lubricated. Okay, They should not be in small size because it can dislodge or it can be ingested. So this is one thing. And you should not put it too hard and too much. Like you are just supposed to fill the gap, the orifice of the endotracheal tube. You don't need to have to have a construction of a house over there. You just have to fill the gap. So it should be small enough or large enough to fill that thing. Okay. And the material should be soft. It should not be irritant, or it should not be very hard. Okay. So these are important thing. Usually in some cases when they are doing oral surgery, sometimes you can request the surgeon to put the throat pack so that it is not hindering their surgical field. Because if you put it a little more or you did not place, because ideally throat pack one end should be outside, but in certain surgeries you cannot do so. But ideally it should be one end should be placed, should be taped outside to the angle of mouth or to the endotracheal tube. Some different people use different technique. Okay. And you have to announce that you put the throat plug, and when you remove it you have to announce. Okay. So these are some of the points about nasal surgery. The middle ear surgery, uh, actually the important things which just a sec, that when they are doing this surgery, sometimes, like for example, this chronic suppurative otitis media, or they have any this this is for mastectomy, and they are doing cochlear implant. Okay. Or other ear surgery like tympanoplasty, um, groma insertion. Okay. So usually they have the same concern that they want a bloodless field. So sometimes they don't want like patient to be hypertensive, because even if a small bleeding is there, it can hamper their surgical field. Then another important thing in this one, especially with cochlear implant or even in mastectomy, that they are doing the facial nerve monitoring. Okay. So now the concern will be that you can give an initial intubating dose, and then either if you have used rocuronium, you have to reverse with sugammadex, or you can intubate the patient with short dose of citracurium, or you can use hexamethonium, that till the time they have reached the dissection level, to that level, the patient should be out of muscle relaxant. Again, you have to discuss with the surgeon what he wants. Sometimes they want a baseline monitoring of the facial nerve. So in that case you have to start the case, and maybe you don't need, sometimes they will ask you to intubate without muscle relaxant. It sometimes become difficult, but of course you have to respect the requirements by the surgeon. But you can go for tiva with this monitoring. Okay. So you can have there is another, we will discuss this topic in some other discussion. But tiva and tci, target control infusion. So there are special pumps which in which you set a blood level, required level. Okay. And then automatically the pump will take the demographics, that height, weight. Okay. And there are some preform models which are placed in it, and usually it is for fentanyl and remifentanil and propofol. Okay. So if it is available, you can monitor the patient with it. But otherwise, you can remifentanil infusion will give a very good uh, status in which there will be hypotension and patient will not require muscle relaxant. Okay. So again, this thing will be important. Then mm, another concern which will be there in this ear surgery is that because there is disturbance of vestibular system. Okay. So this patient is at high risk of PUNP. So one strategy will be to use opioid sparing or opioid free anesthesia. This is one thing. Then actually, because I mentioned this thing in my previous messages, that usually we are giving dexamethasone Okay, or this serotonin receptor antagonist like ondansetron. Okay, we are giving sometimes metoclopramide. Metoclopramide dose required is quite high. So at that dose, there are chances of extrapyramidal symptoms. So actually, because this is not frequently used, but actually this promethazine or chlorpromazine, something like that, like which the antihistaminic, which are sedatives and strong antiemetic properties they have. Okay, so they are preferred or they should be used whenever possible, because maybe dexa and ondansetron will not be sufficient for this thing. Okay, so this is an important thing, and you should try to have good fluid balance, because if this patient is too much like too much NPO, okay, there will be chances of more vomiting. So you have to take care of it, and even a very small thing which sometime you will not appreciate, that when we are transferring these patients, we should not move the trolley too fast, because this will just, after the surgery, this will just give the patient like a roller coaster. Okay, so you have to shift the patient smoothly, and you should not move the trolley or curve the trolley, because when we are coming out of the operation theater, sometime unintentionally we are a little fast and we are curving. So in these patients there will be more chances of vomiting if we are not careful. Okay, so these are few of the points. If anyone wants to ask any question, dexmedetomidine, yes, Presidex. Any question up to till now? Any comments, any question, any wants to add something? Okay. So actually now before I finish, just will take few points about day surgery, because most of these procedures are being done as day surgery. Okay. So usually there is a criteria for day surgery, like if the patient has too much excuse PONV, or patient have, like, there are some exclusion and inclusion criteria for any day surgery, but I am just focusing on the points which will be important with reference to ENT surgery. The key points with day surgery with reference to ENT surgery. So one of them is PONV. Okay, the other problem is with reference to OSA. Okay, because adenotonsillectomy, the patients who have a big adenoids and tonsils, sometimes they are at risk of OSA. So you have to be sure that this patient does not have any element of OSA. Okay, because this will lead to requirement maybe of post-operative admission. So that patient will not ideally be a good candidate for day surgery. Okay, then you should be avoiding long acting medications, uh, like, because with long acting medications with more metabolism. Okay, so like desflurane will be a better choice as compared to sevoflurane. Okay, it is better if you use opioid free. Okay, you should use NSAID, a combination of NSAIDs, paracetamol. Okay, and so that you, like, for example, if you are using dexmedetomidine, the thing which you can expect is slightly delayed recovery you can expect, because dexmedetomidine is strong, like it has, because dexmedetomidine you use sometimes can be very tricky. Okay, so you have to be careful about it. But the good thing about good dexmedetomidine is that it does not cause respiratory depression. Okay, so patient may not be responding much, but patient will be breathing nicely. So this is the advantage versus dexmedetomidine versus opioids. So that's why I still prefer to use. And Then another advantage of dexmedetomidine in these patients will be that the patient will not be that much aggressive as occur in these nasal surgeries. Okay. So these were few points. If anyone wants to add, inshallah, in next session, I will try to have laser and some of the like laryngeal procedures, maybe laryngectomy. Okay. Remember one thing, this ENT is seems to be very simple, but it is very tricky with the reference to exam, because there are certain things in which they can catch you, and you should have a very good concept about the basic anesthesia safety. So basic anesthesia safety is that you should, like, when you are extubating the patient should be awake. Because if patient is like too much deep, patient is not responding well, and sometimes patient is moving the hands or something, but it is not meaningful response. I always see that as soon as the patient starts moving, there is an immediate urge from the anesthesia technician that we should extubate. But my request or my suggestion or my advice will be that till the time patient does not have meaningful response will be either if you are giving a painful stimulus to the angle of jaw with this Larson maneuver, or this jaw thrust, the patient should be moving his hands towards that, or even if you are pressing the sternal area. Okay. Or if you are tapping or calling, patient is opening the eyes. Otherwise, if you extubate in half situation, okay, you can end up in problem, because in other surgeries maybe airway is not involved. Okay, you are not expecting bleeding in the airway in other surgery, but here things will be complicated because of it. So it is better that you can knock down the patient a little bit by giving some lidocaine, or you can give even uh, a small dose of propofol to just to take more time in which the patient's recovery from the anesthesia is adequate. Like, more important thing will be the respiratory involvement, like reversal, like neuromuscular reversal. That's why I, whenever possible, I prefer to use rocuronium, because it will be reversed in a very better way with sugammadex, rather than if you are using other muscle relaxant and you are reversing. Because another point which I will take this opportunity to tell you that usually the dose which we have standard, this 2.5 milligram of neostigmine, okay, with first of all, I always see that people are making with zero point 0.4 milligram of glycopyrrolate. So actually this is not the correct dose. It should be zero point 0.5 milligram, because usually its dose is from so you can take say 50 mics per kg for neostigmine and 10 mics per kg of this one glycopyrrolate. Okay, so usually you can say that, I'm sorry, the dose which we prepare with 2.5 milligram and 500 mics is for 50 kg. Okay, so this is for 50 kg. So just imagine, if you have a patient with 100 kg, you cannot use this dose. You should be giving the adequate dose, that will be 5 milligram and 1000 mics. So people are afraid of giving it, because actually in male adults, if even if the patient is 140 kg, for example, or 150 kg, the maximum lean body weight you are taking is 100 kg. Okay, and for female, you are maximum taking 70 kg. Okay. So this is very important, especially with reference to ENT surgeries, that you should reverse the patient with the appropriate dose, because all of the patients will receive this 2.5 milligram and 500 mics of glycopyrrolate, which is, remember, this is for 50 kg. This is not for your majority of your patients. Majority of your adults will not have 50 kg. They will definitely more than that. So make your habit of calculating the correct dose of reversal. Okay. So this is an important point. So for 100 kg, at least you need 5 milligram of neostigmine with 1000 mics of glycopyrrolate. Okay. So this is important thing with reference to this thing. And if possible, you can monitor the patient with nerve stimulator. Okay. So that's what I wanted to just share. There are very good articles about it. I will share this link to you. And I couldn't get the time to prepare some of the questions related to this one. Just a second, please. So these are actually review articles for with reference to adenotonsillectomy. Some as articles for basic ENT procedures. Okay, we will inshallah discuss the rest part of some laryngeal procedures like laryngectomy and laser surgery. Okay, so you can access them. So I will just finish here. And thanks a lot, all of you, for your presence. All the recordings are there with reference to this channel, because I don't have any financial interest with this. I just do it for all of you. This is, you can say, my passion. So you can find all the playlists here. Okay. And the people who are not from our part of the world, all the discussions which are being done in English will be in this playlist. Okay, otherwise majority discussions are in English, but some of them are in our native language. So you can just have a look. It will take few minutes for you to search, and then you will find all what have been discussed before. Okay. And for anything you don't understand, you can just drop a message with the link of that video you are seeing, and I can help you out with the minute you tell that in this video, in this minute, what you were discussing, we did not understand. So I can always share, or I can always guide you. Okay. With reference to ENT, because some of the discussions I had done before, so you can have a look on it. And inshallah, we will continue our discussion on this topic. So thanks a lot, all of you, for your presence. Any questions before I finish?
Thank you, sir. Thank you so much.
Okay. So no questions means you learned everything or you don't learn anything. Okay. Anyways, I'm optimistic that I gave you something. Thank you very much. Nice to see Abdul Aziz from my hospital. Thanks, Abdul Aziz, for joining. Bye bye. Assalamu alaikum.